Hi, everybody. I'm Dr. Akriti Gupta. I am an executive associate editor at JACC, and it is my distinct honor today to introduce a pioneer, a visionary, and someone who has profoundly shaped the field of interventional cardiology, somebody who needs no introduction, but I would still do one. This is Dr. Martin Leon, who is a professor of medicine at Columbia University Medical Center, where he currently serves as Chief Innovation Officer and Director of the Cardiovascular Data Science Center. Over the course of his extraordinary career, he has left an indelible mark as the founder of the Cardiovascular Research Foundation and the visionary director and founder of TCT, which is the premier global conference in interventional cardiology. His contributions to the advancement of cardiology are truly unparalleled, with more than 50 landmark clinical trials, including the groundbreaking partner trials that really revolutionized how we treat valvular heart disease today. He has obviously done more than 10,000 interventional procedures in his career. And on a personal note, I have actually had the privilege to learn from Dr. Leon as my teacher and mentor. His passion for advancing science, coupled with his unwavering dedication to his mentees, has really left an indelible impression on my career as well. And it is really an honor for me to talk with Dr. Leon today as we introduce the JACC issue for transcatheter tricuspid interventions. The fact that we're talking about transcatheter tricuspid interventions really is because of where we started the transcatheter treatment of aortic valve disease, which has now come all the way here. And Dr. Leon has been at the helm of all of this excitement in this field. Welcome, Dr. Leon. We are very excited to have this conversation with you.
It's a pleasure to join you, and I think your introduction was quite grandiose, but I'm thrilled to try to share some of my perspectives and contribute to this outstanding Jack issue.
Thank you so much. I'm just going to start with an overarching question about how you would describe the evolution of transcatheter therapies, particularly for tricuspid valve interventions, from a very niche concept to a clinical reality, as you have been a pioneer in this space from the very beginning.
Well, Akriti, as you know, we began this whole field of structural heart disease about 25 years ago. And we focused on the aortic valve. There was a tremendous amount of skepticism that we'd be able to develop transcatheter techniques that would be the equivalent to surgical therapy in patients with aortic valve disease. But over the years, with a combination of developing heart team approaches, improving medical imaging, particularly CT and echo, giving us a better ability to properly diagnose and follow our patients, and with training physicians in new techniques, I think over a decade, we achieved credibility that we can treat structural heart lesions with a degree of safety and efficacy that would allow us to compete with other therapies in this space. So naturally, once we had good results in the aortic valve, many people assumed that it would be a relatively easy transition to atrioventricular valves. It hasn't been as easy. And
Correct.
I must say, we've had more than a decade of journey trying to understand the mitral valve and develop the best therapies that would make a difference. We've had certainly some positive clinical results, but we're still struggling in terms of being able to offer ideal therapies to all patients with mitral valve disease. As it turns out, during that opportunity to work in the AV valve space, we became aware that there's much more of a clinical need on the tricuspid side than was previously understood. And now, with patients living longer and realizing that patients are developing tricuspid regurgitation symptoms that previously were either unrecognized, underdiagnosed, or non-treated, that this could be another target. And we learned that in some respects that it might be in fact easier and might be more successful to embark upon a right-sided AV valve approach. So a significant effort has now been launched to try to develop transcatheter therapies to manage tricuspid regurgitation.
Correct. I mean, that is such profound insight into the evolution from the aortic valve to the AV valve space. And, we obviously, that we've conducted the Tricend trial now and the Triluminate trial. The Tricend looked at transcatheter tricuspid valve replacement versus Triluminate that looked at repair. Both of these technologies are FDA approved. In this issue of JACC, we are actually presenting the quality of life outcomes of the Tricend trial and the 1 year outcomes of the complete cohort of the Triluminate trial. So I wanted to ask, what have your learnings been from your experience with both of these trials? I will add that, personally, I was surprised by how little we knew as a community about the tricuspid valve's anatomy and clinical course of disease of tricuspid valve. For example, we learned as we did more and more of this that the tricuspid valve may in fact not be tricuspid for about half the times. It may have 4 or 5 cusps, and that the we don't even know the trajectory of the disease right now. Like, what is a good time to treat it? Is it when you're far out, gone with your RV, or is it early on when you're asymptomatic, or somewhere in between? So would just love to hear your overarching thoughts on how, as a community, we've come such a long way with the conduct of these two seminal trials.
Well, as you pointed out, I think we now have some reasonably good clinical evidence, but this is truly a learning process. And it's almost as if we are um, building the plane as we're flying it. So
Mhm.
there's a lot of learning by doing, especially in the tricuspid space, where the understanding of natural history, the effectiveness of alternative therapies, the ability to get consistent, proper imaging to understand the pathobiology have all been neglected previously. So I think now there's been a revolutionary change over the past 5 years. The imaging has gotten much, much better. And as you pointed out, and I'm constantly reminded by my colleague Becky Hahn that how is it possible that we didn't know until recently that a significant minority of tricuspid valves were not tricuspid, had
Yeah.
either 4 or 5 cusps.
Hmm.
So the anatomy, the physiology, the relationship of symptoms to pathology are significantly different in the tricuspid space. And as we began to learn these things, I think it has impacted clinical endpoints, the way we structure clinical trials. And I think we need to view the tricuspid valve a little bit differently than we've looked at the mitral or aortic valve.
And now that you say that, what challenges do we face predominantly anatomically, but maybe even clinically, when we deal with the tricuspid valve as opposed to the aortic and mitral valve? I think there are three different anatomies completely. And I've also been surprised at how the attempt initially was to enroll in the mitral trials, but we're still waiting for a mitral device while the tricuspid trials enrolled so fast. So, what do you think contributed to that?
Well, I think those are all great questions. I think one of the problems we've had in the mitral space has been we're dealing with remarkably variable anatomy. And between functional MR and primary MR, degenerative MR, and patients that have varying degrees of annular calcification with associated other conditions that affect the mitral valve, I think that the overarching considerations of what anatomic subsets we were treating, I think surprised us. Having appropriate control therapies to be able to compare our experimental transcatheter therapies was also challenging. And that was something that evolved and continues to evolve over time. Certainly, when we deal with things like functional MR, they, then we're talking about heart failure trials, and we're talking about usually heart failure with reduced ejection fraction trials. So a lot of the control therapies relate to optimal medical therapy. And as we all know, that's been radically modified over the past several years. So I think the difficulty in understanding the pathoanatomy, the variability, the difference in clinical course depending upon the anatomy, and trying to understand what control therapies might be applied in clinical research have really plagued us in terms of being able to enroll patients. I think the other issue on the mitral side is that surgery works fairly well in a significant cohort of patients that have primary or degenerative mitral regurgitation. And we cannot deny that comparing to predicate surgical therapy is an important consideration if we're going to suggest that a transcatheter therapy should be either the alternate or preferred treatment in certain patient subsets. So for a lot of reasons, we've had a stall on the mitral side in terms of being able to progress as quickly as we had expected. On the tricuspid space, things are a little bit different in that the controlled therapies are less well understood. Surgery seems to be both less effective and higher at risk. So patients are generally not as good candidates for sole tricuspid surgical therapy. Medical therapy seems to be also relatively ineffective. Diuretics, perhaps, but diuretic resistance is an issue, and multiple other drugs have been relatively ineffective in altering the course of tricuspid therapy. And in particular, the natural history of tricuspid disease is a very long latency period where there is disease progression with relatively few symptoms, and in a time when it becomes clinically apparent and the clinical symptoms are now expressed, patients often have end-stage disease with RV dysfunction, which makes treating them even that much more problematic. So each of these scenarios is very different, and I think we have to take, as you've mentioned, we've got to take them all individually, and we've got to start thinking about better understanding of the natural history. What are the current success and failures and needs relating to control therapies, and we need to structure clinical trials that take into account some of these important differences.
That is certainly so insightful. And with the tricuspid valve disease, I think these trials really brought into focus the importance of quality of life as opposed to the quantity of life. In this issue, I've also authored an editorial with Selena Young and Rasha Alami, who's, Rasha, obviously, who's a world expert when it comes to placebo-controlled trials and really quantifying the impact of placebo on the quality of care outcomes. And these issues became important in both of these trials because, as you know, the primary endpoint was positive, but primarily driven by the KCCQ score or improvement in quality of life. So I guess my question is, how do you envision tricuspid valve interventions shaping this narrative in cardiovascular care? Do we, as a community, are we going to change how we think about endpoints in our trials? We are so used to the hard endpoints of death, stroke, heart failure, hospitalization. Are we okay as a community saying that, you know what, quality of life is as important, if not more, than quantity of life because these patients are older, sicker, and may not care about their longevity as much as the quality. And and uh, and how rigorous do we have to be in how we conduct these future trials to really quantify the placebo effect?
Well, these are great and controversial questions, and we're struggling with all of these right now. This is the first time that we face this issue of seeing what we believe are some fairly impressive and consistent changes in symptoms, which at least patients find to be extremely meaningful. But we have not seen parallel improvements in what we previously called harder clinical outpoints, such as heart failure hospitalizations or mortality. Now, it may be the fact that there's a longer latency period before we begin to see some of these other changes. And a lot of the endpoints that we look at are a little bit too early. When we look at 1-year endpoints as being the definitive primary endpoint for these clinical trials, perhaps we're being naive. And it may be that symptoms are affected first, and over time that we might see changes. And we're beginning to see some of these things as we look at 2 years and 3 years in the TRISCEND 2 study. We're beginning to see what we think are trends that indicate that the hard clinical endpoints are beginning to be modified as well, but it will take longer and the effects may not be as great. So certainly I think that the time course that these specific events express themselves are a little bit different in tricuspid disease, and there is an emphasis on looking at patient-reported outcomes initially as being the first indicator of clinical benefit. So this is a controversial area, and one that really suggests that maybe we should be doing some sham-controlled studies to be able to better understand what that placebo effect is in tricuspid disease. And my colleague David Cohn has proposed, and we are planning, in fact, in collaboration with some European colleagues, to begin doing some sham controlled trials in the tricuspid space to get a better handle on understanding the magnitude of the placebo effect, the duration of the effect, and whether or not this is concordant with other changes in clinical endpoints that we're more commonly applied and that we're more familiar with. So this is a work in progress and an area of great controversy now.
And, to just extend that conversation a little bit further, also in this issue, we have Sanket Dhruva and Kushal Kadakia, who have penned an editorial talking about the health policy implications of these tricuspid trials. So, to that end, I wanted to ask how you think with the growing adoption of these transcatheter tricuspid interventions, what are the key health policy considerations to ensure equitable access? And do you envision that the lack of hard clinical endpoints, would that be a hurdle for optimal coverage? I know at Cedars-Sinai, we often have the conversation as we are doing these interventions that we're probably losing the hospital money, but we have to do the right thing. But in the financial environment, the conversation comes up a lot. So how do you think, having a broad overview of how CMS is thinking about all of this, and um, overall, where is the field going?
Well, it's interesting because CMS has just offered an opinion about their national coverage determination. And I think they accept the fact that clinical benefit can be defined many ways, and the consistency of the effect on multiple quality of life measures, I think, is impressive enough to justify some degree of approval. But during this process of extending national coverage for all patients with symptomatic severe tricuspid disease, there is a concern that we don't have enough data to be able to make definitive decisions. So they have suggested considerably more clinical trials, and those clinical trials would be done over a period of time that would allow the development of evidence and data that would give us greater confidence and understanding of whether or not the clinical effects are real, if they are short term or they extend well into the future, and if they are associated with other important clinical endpoints. So I think that CMS is very attuned to understanding that this is the beginning of what will be probably a decade-long process to accumulate more evidence and better understand both the natural history of the disease itself and the effect of certain treatment modalities. And it also suggests that we'll be doing clinical trials differently. They're suggesting that we not only look at data in the rarefied environment of a randomized clinical trial, but that we look at real world data and that we look at other ways of trying to look at the totality of evidence that would give us more confidence that the therapies that we're applying are justified from a clinical basis and therefore should be reimbursed. So this is having a transformational effect on the way CMS thinks about approval and reimbursement for cardiovascular devices. And I'm excited that they're engaged in the dialogue and are communicating with clinicians and with sponsors to develop some of the clinical research that would help us to get better answers to some of these provocative questions.
So there's a lot of work to do. That's
Yeah.
the sense I get, not only from the standpoint of conducting more clinical trials, but also to shape our observational prospective studies in the real world to inform the evidence generation that will inform our health policy and coverage. So a lot of work to do for the community. This has been so enlightening for me. I always learn a lot when I talk to you. So I wanted to shift a little bit to the personal front, asking you what inspired you to focus on structural heart interventions in your career, and how has that passion really shaped your career?
Well, that's a great question. And um, uh, many times as a physician, you're affected by clinical anecdotes. And when I was a first year medical student at Yale, and we had clinical rotations. I took a rotation in a cardiovascular surgery and took care of a particular patient that had a young patient with bicuspid disease. And I was personally impacted, and she had surgery and she had multiple reoperations. And I was really drawn by the how fascinating it was to truly understand valvular heart disease and how inadequate some of the therapies were. And that case example stuck with me for many years. When I went to the NIH, we began to study the natural history of valvular heart disease with people like Bob Bono, as echocardiography now became a standard clinical technique. And I always dreamed of the time that we would be able to apply non-surgical transcatheter techniques to be able to treat some of these patients that were not good candidates for surgery. So when the opportunity arose and I developed friendships with people like Alain Cribier, it became natural to apply some of our understanding of transcatheter therapies and to develop a new approaches to manage valvular heart disease. And when we had some initial successes in the aortic space, I think that sparked a lot of the continued evolution and now revolution of trying to manage patients with structural heart disease using non-surgical approaches. So I've been fortunate to be surrounded by some really smart people, and they've certainly shaped my thinking. And I believe that for young physicians, that a career in structural heart disease is both gratifying and also exciting because there are going to be so many changes that will occur over the next 10 years.
So now that you talk about the next 10 years, if you had a time capsule and you had to just predict, what do you think this field will look like in 10 years from now? What would be the trials we're doing at that time, and what are the late breakers at TCT 10 years from now? I'm sure you are probably already planning and doing those trials, but I think technologically also there is a huge revolution when it comes to AI, robotics, and I know healthcare is usually the last field to really embrace technology. So maybe 10 or 15, I don't know what the time horizon is, but when we are embracing AI and robotics in a really complete form, where do you think we would be?
Well, first, I agree. Sometimes medicine is behind when it comes to using new technologies to be able to either diagnose or treat patients. But I think we're beginning to catch up. And I think you're going to see that infused in everything that we do. So AI is going to be a foundational point in terms of diagnosis of valvular heart disease, stratification of which patients with which anatomic substrates would be better suited for one or another therapy. I think the procedures will continue to become evolved from the standpoint of improved cardiovascular imaging, which I think is really a foundational aspect of this whole space. And I think we'll get better in terms of being able to train physicians using simulation techniques and using robotics in terms of getting consistent results. So I think the future is going to be remarkably exciting from a procedural standpoint. But I would also look at it a little bit differently. We mentioned that we're not seeing differences so far, dramatic differences in mortality and in heart failure so far in tricuspid interventions. And I begin to think that perhaps there's a common thread that under many circumstances, we're getting to these patients too late. And I think earlier recognition, earlier diagnosis may have a big impact in terms of being able to get a more complete reversal with some of our transcatheter or surgical therapies. So I think that the continuum of early access, early diagnosis, adjusting some of the trigger points for therapy to be able to optimize what the effects a device might achieve, I think are going to be part of the story. I also believe that we need to look more closely at the patient's post-procedure. We tend, as structuralists, are very satisfied when we do a procedure and we think it's successful. I think the reality is that many patients have either incomplete results or they have recurrence. And I think the idea of being able to look at the procedural failures and being able to understand who are the responders, who are the non-responders, and then thinking about how we can better address that non-responder population is going to be an important component of the future. And I think part of that is going to be the ability to be able to successfully apply pharmacologic therapies at an earlier time to manage some of the post-procedural non-responders. So even though we are technologists, we understand technique and procedures, I think we also have to be physicians, and we've got to
Mhm.
hone our diagnostic skills, and we've got to be closely involved in the patient care post-procedure, either ourselves or with our heart failure colleagues, to be able to optimize the ultimate procedural outcomes. And that's what we now call this lifelong journey of managing patients with valvular heart disease. So I've drifted from just focusing on the index procedure and trying to get better at understanding what are some of the pre-procedural diagnostic areas that we should focus on, and post-procedure, who can we identify as patients that need further help.
That is so meaningful, especially for the young generation and the early career cardiologists and researchers who are aspiring to become structural heart valve interventionalists. That first and foremost, you have to be a physician and a doctor, and not forget all of that, because I can relate. You do the procedure; it is extremely gratifying, but I think thinking about everything before and after the procedure forms such an important part of being an excellent interventionalist. Finally, I would ask if you have any advice for early career faculty like me, and then obviously fellows who are dreaming to emulate. I'll just share a personal anecdote. When I was interviewing for cardiology fellowship at Columbia, and I knew I'm supposed to talk to you, I actually watched so many of your interviews from before that, and I thought that's like a dream come true to be able to even be in front of you. So I think a lot of the young audience is going to really appreciate some words of wisdom from you today.
Well, several things. First, I enjoy having an opportunity to work with my early career faculty and my fellows, and there's no greater joy than to be able to influence people during the course of a point in their career where they have to make significant decisions about how to pursue their futures. So for me, it's a joy to be exposed to such talented people. I feel very confident that our subspecialty is in good hands because I see so many qualified young people that I'm thrilled to be exposed to that. In fact, humbled. But other areas of advice I would say is that certainly structural heart disease is as much imaging as it is the technical procedural aspects. So I would advise anybody who's interested in this space to really acquire advanced skills in cardiovascular imaging. So that's, of course, that's CT, that's echo, that's CMR. I think all of these techniques are going to be fundamental to being able to optimally take care of patients. I would also say that it's really good to focus, and it's nice to be a mile wide and an inch deep, but it's much better to really achieve an understanding of one area in greater depth. So I would suggest that people really should, as they're training, develop special expertise, advanced understanding of certain areas, and that will really help them to contribute to the clinical and academic process. I have colleagues at Columbia now who are focusing on structural heart imaging, others that are focusing on hemodynamics as being an important area that needs to be redeveloped in our understanding. Others who are developing really good skills in heart failure therapy to be able to manage these patients from a combined device and pharmacologic approach. So I think there's so many opportunities for young physicians to become involved, pick a mentor, get involved in clinical trials. I think there's no substitute for a density of clinical experience. So be part of a lot of clinical cases. And I think over time you acquire a skill set in areas of preference that begin to distinguish you. And there's no more better example than yourself, Akriti, because in a very short time, you become an expert in so many areas. And I think I'm very confident that many of your younger colleagues are going to follow that same route. And I'm just hopeful that I can continue to participate and influence the field and influence their career pathways.
Thank you so much for your kind words, Dr. Leon, and it has truly been such a treat for me to have learned from you and continue to learn from you on an ongoing basis. And for our audience, I think this was such an amazing interview, and I certainly learned so much. So I know that our audience is going to learn a lot. Thank you so much for your time, Dr. Leon. I know how precious it is. Every time I send you an email or ask for something, I feel like I'm taking away from the world in some way. So thank you for making the time and have a great weekend.
Thank you, Akriti.